Hi guys, welcome back to the channel. Today we are discussing the ATACH 2 and INTERECT 2 trial. Intensive blood pressure lowering in the patient with acute cerebral hemorrhage. This is a landmark trial for the ICP monitoring or blood pressure monitoring in acute cerebral hemorrhage.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of son whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study. In the patient with acute intracerebral hemorrhage and who are hypertensive, does rapid lowering the systolic blood pressure compared to the standard therapy improve the patient outcome? Design for the study. This is a randomized multi-center open label study. Centralized randomization using the trial website for minimization algorithm combined with a bias coin method. Follow-up period for 3 months. Power calculation based on assumption that death or disability would be the 10% lower in intervention group. Expected control event rate of 60%. Alpha error point 0.5 power 90%. Sample size of 1280 patient required to taking into account non-adherence to study and intention to treat analysis. Setting for the study. 110 sites in United States, Japan, China, Taiwan, South Korea, Germany, and duration for the study is May 2011 to September 2015. Population for this study. Inclusion criteria: 18 years or above age may be required. GCS more than 4. Intraparenchymal hematoma or less than 60 cm on initial CT scan or within 3 hours extended to the 4.5 hours of symptom of onset. At least one reading of systolic blood pressure of 180 mmHg or more between the symptom onset and the initiation of intravenous antihypertensive treatment. Exclusion criteria for the study: time of symptom onset not reliably established, previously known as intravascular malformation, arteriovenous neoplasm, aneurysm, intracerebral hematoma considered to be related trauma, ICH located in frontotemporal region such as pons or cerebral, IVH associated with the intraparenchymal hemorrhage, blood completely fills one lateral ventricles or more than half of both ventricles. Subject is considered to be candidate for the immediate surgical intervention by the neurosurgery service. Pregnancy or parturition within a previous 30 days, active lactation, any history of bleeding, diathesis, coagulopathy, use of warfarin within the last 5 days, platelet count less than 50,000, known sensitivity to the nicardipine, premorbid MRS for more or greater, subject living will be precludes aggressive ICU management. Total 8,532 patients screened and 1,000 is randomized. Intervention for this group. Treatment could be initiated before the randomization to lower the systolic blood pressure or less than 180 mmHg, but were excluded if systolic BP reduced below 140 mmHg before the randomization. Target systolic BP is 110 to 139 mmHg throughout the 24 hours after the randomization. Control group. Target BP 140 to 179 mmHg throughout the 24 hours after the randomization. Management common to both groups. First line IV nicardipine infusion initiated at 5 mg per hour, increased by 2.5 mg per hour every 15 minutes as needed up to the maximum dose of 15 mg per hour. Second line, if target is not achieved after the 30 minutes, IV labetalol, IV diltiazem or urapidil. If labetalol not available, you can use this diltiazem or urapidil. Outcome from this study. Primary outcome: proportion of a patient who had a modified ranking score 4 to 6 at 3 months, significantly disability or death. No difference between the 38 point versus intervention group and 37 in control group. unadjusted analysis relative risk, and adjusted analysis relative risk. Secondary outcome: unadjusted analysis showed no difference between the groups of EQ-5D score at 3 months, VAS score at 3 months, proportion of a patient with an expansion of 33 or more than volume hematoma on 24-hour scan compared to the baseline scan. Safety outcomes: fall in GCS by 2 or increase by NIH score by 4, incidence of serious adverse events within 72 hours, higher incidence of severe adverse events within 3 months in intervention group when analysis adjusted, 25% in intervention, 20% in control group. Primary treatment failure not achieving the target within 2 hours after the randomization, 61 in intervention and 4 in control group. Secondary treatment failure: hourly minimum systolic BP of target range for 2 consecutive hours during the period up to 24-hour randomization, 78 in intervention and 7 in control group. Primary outcome: intervention, death or disability, only 38.7 and 37.7. No difference, only 1% difference. Secondary outcome: hematoma expansion, 18.9, 24 in control group. Neurological deterioration within 24 hours, intervention in 11 and control 8. Serious adverse events within 72 hours, 1.6, 1.2. Serious adverse events within 3 months, 25.6, 20. Death in 6.6 and control is 6.8. No difference. And EQ-5D was median 62 point in intervention and control 70. Strength for this study: multi-center trial, clinically meaningful or relevant outcome measures. Weaknesses: recruitment criteria changed during the trial. Reason for failure to randomize screen population not included. Underpower, power calculation based on event rate of the 60. Actual observed event rate study is 38%, increasing likelihood of type 2 error. More than 50% of patients recruited from Asia sites and may not be reflective of a European population. Intracerebral hemorrhage group as a single entity. Significant difference between the group of regard of treatment failure, primary or secondary. Author conclusion: the result of this trial do not support the reduction of systolic BP blood pressure to the target of 110 to 139 mmHg in intracerebral hemorrhage. And bottom line for this study: the result of this trial and that of the INTERECT 2 trial do not support an earlier intensive control of systolic blood pressure in patients with acute intracranial hemorrhage.